Good morning, Professor Go Kwok Chow, Associate Professor Le Kak Bao, distinguished teachers and colleagues. It is a great honor to report today on a topic that Professor Chow introduced earlier, concerning two new vaccines in Vietnam. Through this presentation, I would like to focus on something that, until now, our respiratory physicians have primarily concentrated on: managing the burden of disease, particularly in COPD patients and other respiratory patients. However, now we are looking at it from a different perspective. From the perspective of a treating physician, we can add another perspective: preventing adverse events, especially respiratory infections, to best protect our patients. And among these, two important ones are shingles and RSV. We begin with an image of the patients we encounter daily in our wards. These are elderly patients with multiple comorbidities and a high burden of disease. Patients aged 50 and older already have an aging immune system. They have many comorbidities and are constantly at risk of exacerbations. As Professor Bao mentioned in his presentation, they are constantly at risk of and fearful of exacerbations. And our treatments, such as corticosteroid treatment for these exacerbations, make our patients very vulnerable to infectious agents. We know that these infectious agents can attack from within or from without. The internal attack risk is that our patients may experience varicella-zoster reactivation. Because we know that 90% of our population carries the varicella-zoster virus, and when we have been infected or have been exposed, the virus will remain in our bodies in the peripheral nerves. And when we are weakened, when we are 50 years old and have many comorbid diseases, it will reactivate. That is the risk from within. And this reactivation will cause shingles. In addition, our respiratory patients also have many external factors from air pollution, especially infectious agents. And the infectious agents here, because my presentation is about RSV, and RSV is an important infectious agent that is often underestimated. Perhaps pediatricians are very familiar with RSV. However, RSV in adults is still not given enough attention. And in the US, they say that this is a hidden iceberg. So we see in this image that our patient is a high-risk group and the burden from shingles is a potential risk from within. This slide summarizes the two-way interaction between herpes zoster, shingles, and COPD patients as well as elderly asthma patients. We see that the risk of shingles in COPD patients in the population increases by 41%, which is a very high risk, and this is very large and statistically significant data. And what about asthma patients? For asthma patients, the risk of shingles increases by 24% compared to the general population, and there are many reasons for this. And if we have specialized sections on this issue, we will explain many reasons, including the imbalance of Th1 and Th2 immunity and treatment with our medications. And in addition, there will also be a two-way interaction. Here we see that our patients will have a 53% increased risk of post-herpetic neuralgia. And for COPD patients, and for asthma patients, this risk also increases by 21%, which is not insignificant. The increased risk of infection in our patients is a problem. And after contracting the infection, they also have an increased risk of complications, especially post-herpetic neuralgia, which seriously affects the quality of life of our patients. Furthermore, it not only seriously affects the quality of life but can also trigger acute exacerbations in our patients. We see that COPD patients who contract shingles have a 2.7 times increased risk of acute exacerbations and a 26% increased risk of worsening symptoms, such as shortness of breath or other symptoms, and a 12% increased risk of a severe COPD exacerbation. Clearly, there is a two-way interaction with shingles. That's the potential risk from within. And what about external factors? Externally, our patients are exposed to many external agents, as Dr. Chow mentioned, such as bacteria and viruses. Especially today we are talking about RSV, and this risk is always present from the environment. And these are surveys on the incidence and complications of COPD and asthma patients. We see that 20 to 40% of our COPD patients are likely to contract RSV, respiratory syncytial virus. What about asthma patients? 10 to 30% of asthma patients are at risk of contracting RSV in adults. And again, this burden is always underestimated. And when our patients contract RSV, they will have increased exacerbations, an increased rate of patients requiring mechanical ventilation, and an increased rate of complications, especially mortality. Here are some very specific numbers from a study here. A systematic review of the RSV burden in adults aged 18 and older in high-income countries. Here, we are looking at studies conducted in high-income countries from 2000 to 2023, based on 25 studies, and the numbers are very impressive. We see that 56.8% to over 83% of our patients are likely to experience a COPD exacerbation if they are infected with RSV, and 17% of them require ICU admission, with mechanical ventilation potentially reaching 21% and mortality up to 17%. Clearly, this information gives us a perspective that we need to consider. This is a very important issue that we need to pay more attention to, especially for adult patients. Fortunately, we already have very effective vaccines against these two agents. Here, we will look at two large randomized, double-blind, placebo-controlled trials, Z050 and Z70. We have several studies, but I will present the Z050 and Z70 studies. We see the efficacy of the RSV vaccine. Here, we might confuse the two abbreviations. RSV is the recombinant herpes zoster vaccine, while RSV is the respiratory syncytial virus, so there might be a little confusion. This is the efficacy of the RSV vaccine in preventing herpes zoster and related complications. We see very high efficacy across age groups, over 50, 50 to 59, and 70 years and older. We see that the protective efficacy against the disease can reach up to 97.2%, a very good protective efficacy, as well as efficacy in preventing complications. Here, the complication we are most concerned about is postherpetic neuralgia and other complications, which can be prevented by 93%, including ophthalmic herpes zoster and disseminated herpes zoster. Disseminated herpes zoster is very severe. Shingles in the eyes can cause blindness. Shingles and postherpetic neuralgia are also major concerns because they profoundly affect the patient's quality of life. We also question whether this vaccine provides long-lasting protective efficacy and its safety in vulnerable individuals. Studies have shown that the recombinant shingles vaccine, RSV, can provide protection for up to 11 years and has a high safety profile. Regarding safety, we know that before this recombinant vaccine, there was a live attenuated vaccine. However, many countries no longer use it because our target group is vulnerable individuals with weakened immune systems, and using a live vaccine would certainly not guarantee safety. Therefore, many countries have stopped using it. Today, Vietnam will be using the recombinant shingles vaccine, which is non-live and safe for these sensitive and vulnerable individuals. We will also be interested in the protective efficacy of this vaccine, especially in the respiratory patients we are focusing on today. For the patients we interact with daily as respiratory physicians, the protective efficacy is also very high, ranging from 88% to 84% in asthma patients and other respiratory patients. In fact, 3 days ago, I received the shingles vaccine. Before giving this presentation, I also got vaccinated to gain more experience to advise patients. We will also discuss a second vaccine, the RSV vaccine, which is also very new. Less than control 100 greater than here. This study design was conducted on a very large study population of over 25,000 people, and we will compare it to a placebo in those who received the vaccine. We will evaluate it over different RSV seasons, and each season will be 1 year. Currently, the data prescribed in Vietnam is only for season 1. Therefore, I would like to present the efficacy and protective effect of the RSV vaccine for only season 1. Regarding the efficacy and safety profile of the adjuvanted vaccine for preventing lower respiratory tract disease caused by RSV. Here, lower respiratory tract disease due to RSV has 2 forms, one is acute, and the other is lower respiratory tract infection. The efficacy of RSV prevention against lower respiratory tract disease, specifically lower respiratory tract infection caused by RSV, shows a protective efficacy of 82.6%. For those with underlying conditions, such as heart disease, lung disease, and respiratory diseases, the protective efficacy is 94.6%. And for the objective of protecting against severe RSV respiratory infections, the protection rate is 94%. Most adverse events were acceptable and generally safe. These are the preventative efficacies of the RSV vaccine against lower respiratory tract infections and acute respiratory infections in elderly adults with underlying conditions. For those with more than 2 underlying conditions, the protective efficacy is up to 92%, and for those with 1 underlying condition, it's up to 94%. For different medical conditions, including cardiovascular and respiratory diseases, the protective efficacy is 88%, which is also a very high protective efficacy. A question arises. Because our target population is a vulnerable, sensitive, and easily injured group. Because in elderly people, the immune system is weakened due to immunosenescence, and in people with multiple underlying diseases, what kind of vaccine should we create? Firstly, it must ensure safety. And secondly, it must ensure that the vaccine elicits a good immune response in the patient. When their immune system is already weakened, these 2 questions are addressed by modern medicine through the invention of types and designs of vaccines that meet these requirements for vulnerable individuals. Firstly, it must ensure good immunogenicity in contexts where the immune system has already aged. And we must choose an antigen target that is both immunogenic and safe for the patient. To address this, we have many strategies. Among them, we hear about strategies such as, for example, in influenza vaccines, they will have a higher antigen content. For example, high-dose influenza vaccines, which we have heard about and seem to be coming to Vietnam soon. In addition, we will have a vaccine formulation with an adjuvant, and the emphasis here is on the adjuvant, and many types of vaccines use adjuvants to enhance the effectiveness of the immune response. And another way is to use alternative routes of administration. For example, the influenza vaccine. Influenza vaccines are usually injected intradermally or subcutaneously, but there is a method where they are injected intradermally to allow the immune cells under the skin to mount a strong immune response. That's how they design vaccines to overcome the problem we're discussing in people with weakened immune systems. So, these 2 types of vaccines share a common scientific foundation in advanced vaccine technology. Here we see on the left a recombinant JTER vaccine. On the left side, we use a recombinant antigen, which is glycoprotein E. It is located on the glycoprotein spike layer of the varicella-zoster virus. We don't take the entire component, but only a small part of it. This ensures sufficient immunogenicity while being safe because it is non-living, making it safe for the patient. Looking at the right side, the RSV-Ref vaccine also uses a recombinant antigen, but it's the pre-fusion F protein. Here, we know that the F protein is the membrane fusion protein of the RSV virus, and we use the pre-fusion form to create the best immune response. So, we have a common formula here. These two recombinant antigen proteins are combined with an adjuvant system. And what's different about this adjuvant system? This adjuvant system contains MPL, which is a detoxified derivative of lipopolysaccharide from Salmonella minnesota. And the other component is QS21 saponin, a natural crystalline saponin molecule from the soapbark tree. These two substances are incorporated into 100 liposome cores. This is a formula that creates a strong immune response. That means two vaccines but using a common adjuvant system. However, this adjuvant system will also differ slightly between the two components, both using MPL and QS21 saponin. However, the composition of each component is slightly different, but generally, they use this adjuvant technology to create a strong immune response. And for the RSV ref vaccine, we also use the same adjuvant system. That's the principle. And this groundbreaking common point is the non-living recombinant technology to ensure high safety, suitable for vulnerable individuals, those with chronic underlying diseases, and those with immunosenescence. Our antigen is a purified antigen to focus the immune response on the weakest point of the virus to increase the specific immunity of the patient. And the adjuvant system here is advanced to overcome the barrier of immunosenescence and provide a strong and sustainable immune response. That's our vaccine technology. And actually, we have quite a few recommendations. Here we see that we are very familiar with them. For example, the CDC and ACIP all recommend RSV vaccination for patients with chronic diseases. For example, including respiratory diseases and shingles. We are also familiar with the GOLD guidelines. GOLD gives us a series of about 6 vaccines that we need to guide our patients on. These include shingles and RSV. Shingles for those over 50 years old and RSV for those over 60 years old. Regarding the asthma guidelines, we also see that asthma patients are at risk of COPD, so we should consider advising and vaccinating these patients. Of course, we must assess each patient individually. And the GINA 2025 guidelines also recommend that asthma patients should be vaccinated against RSV in addition to other necessary vaccines such as influenza, for those over 60 years old. These are international recommendations. And to clarify further, these recommendations on RSV and shingles are also international recommendations, and the Vietnam Respiratory Society was one of the first and very quickly adopted these updated vaccine recommendations. Fortunately, today we have the latest recommendations from the Society on Chronic Obstructive Pulmonary Disease and Community-Acquired Pneumonia. Very quickly, these two vaccines have been updated and are being used in certain populations, including asthma patients, as well as those at risk of community-acquired pneumonia, and in specific age groups. We've heard about the theoretical aspects, so the question arises in clinical practice. These are clinical case scenarios that we can actually apply. General prevention strategy. A 68-year-old male patient with COPD group E, experiencing frequent exacerbations and using ICS/LABA, meaning he's on triple therapy. The question is, what is the order and timing of the shingles and RSV vaccinations? The question is, this patient is already high risk, so vaccination is very important. To date, there is evidence that we can administer the shingles and RSV vaccines together, as well as with other vaccines. Or, if the patient is not ready, we can administer them 2 weeks apart. Of course, we cannot ignore other vaccines either. These are the questions for the first scenario. Here's the second scenario. A 62-year-old female patient with severe asthma, grade 5, who is on low-dose maintenance corticosteroid treatment and even biological therapy. The question is, what should we consider regarding the interaction and immune status of this patient? Of course, our asthma patients need vaccination, and we must assess the best timing for vaccination. The fact that the patient is using low-dose maintenance corticosteroids and biological drugs is not a problem for recombinant vaccines. One more question, another scenario. A 75-year-old male patient with COPD group B, diabetes, and cardiovascular disease, including ischemic heart disease. How should we advise this patient regarding vaccination? So, for this patient, vaccination is definitely very necessary because vaccines are not only needed for respiratory diseases, but this case also has many cardiovascular risk factors. Currently, vaccines have been shown to have a protective effect, even primary protection, for patients with cardiovascular diseases such as myocardial infarction and stroke. Therefore, we see that even cardiologists recommend vaccination more often than respiratory specialists. The indication for vaccination is more frequent from cardiologists than from respiratory specialists for this reason. Therefore, for this patient, we will provide comprehensive advice, protecting both respiratory and cardiovascular health. And some notes in practice. Firstly, contraindications and postponements. Absolute contraindications, of course, are that if our patient is allergic to any component of the vaccine, we will not vaccinate them. This is obvious. Temporary postponement is necessary if the patient is experiencing an acute asthma exacerbation or COPD exacerbation, or has an acute infection of moderate to severe degree. Also, if the patient is pregnant or using high-dose immunosuppressant drugs, high-dose, colleagues. Low doses are acceptable. And some practical considerations. We can administer the RSV vaccine and the RSV shingles vaccine simultaneously with other vaccines such as influenza or pneumococcal vaccines, but we must ensure that they are injected at 2 different sites. Another common question is whether people who have already had shingles or RSV need vaccination. The vaccine is still needed to prevent reinfection or reactivation of these 2 pathogens. And during vaccination, we should also remember these 4 teraseconds, for easy recall by colleagues. In reality, the theory of vaccination is easy, but the problem lies in conveying that message to the patient and even to ourselves. After much consideration, I decided to get vaccinated, and I realized that we still have a long way to go in terms of understanding and knowledge, but changing our actions is also very difficult. I'll just briefly summarize the 4 T principles of communication in vaccination. We must be empathetic, we must listen, and we must understand our patients. Especially with vaccinations, they are very afraid of safety issues. And we must build trust, show our patients that it's based on scientific evidence, and be direct. When recommending vaccination, we must be direct and strong, not just saying, it's okay if you get it, it's also okay if you don't. That's not acceptable. We must recommend it directly and strongly, and we must give our patients convenient, clear, and easy-to-follow solutions. A vaccination clinic where patients have to go up and down, pay money, and then get vaccinated will surely discourage them. So, these are the 4 T principles in vaccination. From this issue, we understand that we should reposition the role of our respiratory physicians. We are used to dealing with the consequences, but we are not used to preventing them from the beginning. As respiratory physicians, I think I myself also need to change a lot. We are used to treating complications, but we don't address the underlying issues that cause these complications. From being a treating physician, we should become a comprehensive protector for our patients. Someone once said that a good doctor treats complications, but an excellent doctor prevents complications from occurring. Our take-home message today is that we must recognize the dual threat. Our respiratory patients are targets of many agents, including shingles and RSV, and we need to trust the scientific evidence regarding these new generation vaccines, which are highly effective and safe, especially for this vulnerable patient group. We need to build a comprehensive protection plan for our patients. Besides non-pharmacological measures, vaccination is not an additional service, but a standard of care that includes vaccines for influenza, pneumococcus, shingles, RSV, and other vaccines in our routine care process. We also need to proactively act today so that every consultation we provide will ensure the safety of our patients for many years to come. That concludes my presentation. Thank you very much to the professors and colleagues.